For pregnancy and lactation professionals and parents-to-be, the First Exposure podcast offers safety information and clinical guidance about medications, drugs, and environmental exposures. Join us at firstexposure.ca.
Welcome to First Exposure's podcast, where we discuss health topics using the most up-to-date scientific evidence of interest to community members who are pregnant, planning a pregnancy, or recently given birth. I'm Dr. Tali Bogler, medical advisor at First Exposure, an academic family physician, and chair of family medicine obstetrics at St. Michael's Hospital. I'm also a mom of 3. My youngest is 2 years old. And today we're talking about mental health during pregnancy and postpartum, a topic that affects so many, yet is often surrounded by stigma, uncertainty, and barriers to care. Mental health conditions like depression and anxiety are very common in pregnancy and postpartum, but many people hesitate to seek treatment, whether it's due to fear, misinformation, or lack of access to care. And today I am joined by Dr. Cindy Maxwell and Dr. Simone Vigod. Dr. Cindy Maxwell is the medical content director at First Exposure. Dr. Maxwell is a maternal-fetal medicine and obesity medicine specialist and professor of obstetrics and gynaecology at the University of Toronto. Dr. Simone Vigod is a psychiatrist specializing in pregnancy and postpartum mental health. She is head of psychiatry and a researcher in the area at Women's College Hospital and a professor of psychiatry at the University of Toronto. So welcome to both of you. Thank you so much for coming on today. And if it's okay with you, we're going to get started. So let's jump right in. So I'm going to ask the first question, and I'm going to turn to Dr. Vigod to answer this first question. So mental health conditions are, as I mentioned, very common in the perinatal period, but just how common are they?
That's such a good question. As you said, Dr. Bogler, depression, anxiety, and conditions that we call related to anxiety, obsessive compulsive disorder, or post-traumatic stress disorder. Collectively, all of those conditions, plus some of the more rare and serious mental health conditions like bipolar disorder, schizophrenia, if you take all of it together, we're probably talking about at least 1 in 5 pregnant people and postpartum people are experiencing some sort of mental health condition or some sort of struggle with their mental or emotional health. And I often say to people, we have about 400,000 births every year in Canada. And so if my math is right, that means we're talking about 80,000 pregnant and postpartum people and their children across Canada every year experiencing these kinds of conditions.
Wow, it's very high. And as you said, there's depression and anxiety in the general public outside of pregnancy. How can depression and anxiety sometimes present perhaps differently in the perinatal period? Specifically, I guess, maybe we should back up and even explain what does perinatal mental health even mean, the perinatal period. And then if you could just explain, how can it sometimes present in pregnancy or even postpartum?
Yeah, so generally when we're talking about the perinatal period with respect to mental health, we're talking about the time from when a person first conceives or becomes pregnant all the way through the pregnancy, the labor and delivery. And generally, we usually think about it till about a year postpartum. Is that a hard and fast rule? Absolutely not, right? In some of the diagnosis books, they talk about if you're going to have an onset of a perinatal mental health issue, it means onset during pregnancy or within the first 4 weeks postpartum. But like you were saying before, sometimes things start and then they don't really come to attention until later. And so that 1 year mark is really something, a lot of people also, when you're talking about lactation and breastfeeding or chest feeding, a lot of people do that until a year postpartum. So there are special considerations. So in general, we're talking about the time of conception up until somebody delivers. And I would argue, and I think you might agree with this as a family physician, is maybe we should also be thinking about the preconception period as part of this too, because a lot of people come into pregnancy, like you said, depression and anxiety are common in, people who are female and of female sex and reproductive age who can become pregnant, right? So a lot of people come into pregnancy already. And if we can actually counsel them in the preconception period and get them better before they even get pregnant, we'll be way ahead of the game. So I kind of like the idea of saying, let's also include that preconception time.
I agree. I actually always thought it was the preconception time as well. And I think it's a very important time when we talk about preparation. You know, we prepare people to get pregnant in so many ways, whether it's weight or chronic conditions. Mental health is just one other piece that people need to look at when they're thinking about conceiving and preparing to bring a baby into, you know, and grow their family. So thank you for that. So, and then in terms of the symptoms, so many people might be familiar with what depression looks like or anxiety, but how does it kind of present itself in pregnancy or postpartum?
Well, I think one of the things that happens with depression is, you know, you think about the main symptoms are feeling sad or feeling a lack of motivation or being uninterested in things. But a bunch of the accompanying symptoms are problems with sleep, problems with appetite, problems with concentration, feeling slowed down or restless or off, right? So what can often happen in pregnancy is, how do you distinguish between your nausea and your fatigue and your physical discomfort and getting up at night to pee? Like, how do you decide that that's depression or anxiety? And, you know, and even things like worrying, right? Like, it's not unreasonable to be concerned about, you know, certain things happening, especially if you're pregnant for the first time or if you're having a complication, right? How do we distinguish between what is sort of reasonable or a physical symptom of pregnancy and is just going to pass versus what's actually a mental health issue requiring treatment? And that's really hard, right? Because you certainly don't want to make people feel like every negative feeling they're having is a mental health issue, right? But you also don't want to miss something. So I often talk to patients I talk about stickiness and severity. So I often say, you know, if you have like one negative thought, or let's say after your baby's born and you're really tired and like you have one negative thought, oh, I'm not a good mother or I'm not whatever, but then it goes away pretty quickly and you're able to pretty easily tell yourself, no, I just got frustrated for a minute. You bounce back pretty easily. Like, that's much less to worry about than if you're starting to have like intrusive thoughts about horrible things happening to your baby all day, all night. It's keeping you up. You can't let it go, right? So more an indication that there's an issue. And then also the severity and the impact on functioning, right? Like, how severe are the feelings? You know, it's if somebody's having thoughts, for example, about wanting to not live anymore, that would be quite serious, right? So I often think about the stickiness and the severity. And, you know, you asked about, are the symptoms different? They're not necessarily different in pregnancy and postpartum, but sometimes they can be really focused specifically on pregnancy and postpartum, right? Like, you think in depression, you have a lot of negative thoughts, but in the postpartum, let's say, a lot of those negative thoughts might be about your parenting or about your ability as a parent, for example. Or the things you're worried about, a lot of worries about child's health or bad things happening to them, right?
Right. They might shift. The content might shift.
Yeah.
Okay. I like that. I like that concept of the stickiness. I might use that in my practice. Cindy, a question for you, because you're seeing patients all the time in your pregnancy clinics. You know, why do you think there is the stigma around mental health, you know, and specifically in the perinatal period? Like, what do you see in your patients in terms of the hesitation perhaps to bring things up, or when you do bring things up, you know, potentially the hesitation to see whether it's a psychologist or a psychiatrist to get extra help, you know, in the perinatal period?
That's a great question. I still think there is considerable stigma attached to mental health and to mental illness, and people do seem reluctant to speak about these issues. Sometimes we have to think about the setting where we're talking to patients about mental health and whether they're comfortable discussing those issues, let's say with a family member present or if they've brought their other children to the visit. It can be the context, it can be just their sense of perhaps shame or discomfort in talking about those kinds of issues. But as I've heard Dr. Vigod say, I believe in the past, we talk about different parts of our bodies and how they function well and when they experience illness. And so too with the mind and with the brain, and that it's another way that we have to think about our health. And that is being able to discuss our mental health. I think it's helpful if, as a clinician, we open the door to the discussion. And I do appreciate the stickiness and severity idea. I think that I might use that actually in my practice going forward as well, to really engage our patients in discussions about how they're feeling. I mean, it's part of our prenatal care for sure to talk about mood and emotions and how people are coping with their pregnancies. In my world, where I take care of people who are pregnant, who have chronic or acute medical conditions in pregnancy, these are generally associated with quite a bit of stress. And so it's always a topic that I bring up every prenatal visit, and certainly in the postpartum as well. And I think being open about the issues, being direct and talking about these issues with patients, I think is one way to decrease general discomfort with addressing the issues in the context of pregnancy care.
Thank you. Thanks, Dr. Maxwell. Dr. Vigod, and this is more, I'm asking you as a specialist in psychiatry and reproductive health, what do you think we could be doing better as healthcare providers? I'm a family doctor who does obstetrics, and Dr. Maxwell is a maternal-fetal medicine specialist. I know there's a little bit of controversy. Should we be screening all our patients? What can we be doing better to make our patients, one, feel more comfortable to bring this up? Should we be asking at every prenatal visit? We run very busy clinics. There's often, as you said, Dr. Maxwell, the setting is so important. If it is a little bit more of a rushed appointment, how do you ask these important questions in a sensitive way that they don't feel rushed to be able to open up? Basically, what can we be doing differently? What would you suggest?
So we recently published the Canadian Network for Mood and Anxiety Treatments, CANMAT, clinical practice guidelines for the management of perinatal mood, anxiety, and related disorders. And this is a section there about, identification. And there are a few points that I think are important. I think it's important that people know and providers know that patients generally report that it's very acceptable to ask them, right? So, asking them isn't going to make them say, oh, gee, maybe isn't going to create a problem. But they do need to be asked, sensitively and privately, in the same way that we think about, perhaps asking about something like intimate partner violence, right? Like there are certain things that you need to ask about in an appropriate setting. But I think the neat thing that we found from the literature is that there are lots of ways to ask, right? You can ask directly with two questions, just, have you been feeling sad or down? Have you been feeling less interested in things? That has actually a pretty good sensitivity for picking up possible depression. And, you would have to follow that up with all, is it really, et cetera, et cetera. But that has pretty good sensitivity. But it also works to provide like longer questionnaires for patients that they could maybe, fill out on their own and then submit to you. Right? So I do think one of the things is to find a way to routinely ask during the pregnancy, and that can be done at routine visits, but think about the fact that there are many different ways. There's probably not one right way. And to the other point, there's some evidence that suggests that sometimes providers don't ask because we don't have good pathways of what to do next, right? So it's a bit scary to bring something up with a patient if they say yes, and then you're like, okay, and what do I do now? I do think, and that's the same thing with any kind of case identification, right? Like, can you imagine if we did mammograms and then if we identified something, we just said, okay, right? So I do think, the health system and us as specialists have a responsibility to all of the practitioners who see patients, for their antenatal and postnatal care, to have pathways for you to be able to do something if you get a positive result.
Yeah. And I do think, sorry, my throat, I do think healthcare providers are pretty good in the postpartum period. There's been a lot more awareness about that, a lot of focus on asking about that. I just do wonder from my own clinical practice and seeing other providers if we're doing enough in the pregnancy period during routine visits, since they are quite frequent, and you think you get to know the patient, you don't need to ask all the time, that often it's not necessarily asked at a routine visit.
Yeah. And, the biggest risk factor for postpartum depression, do you know what it is? It's in fact untreated depression during the pregnancy, because it doesn't just go away generally, right? So considering how common these issues are, if we're trying to prevent longer standing problems, we really should be trying to identify and provide treatment during the pregnancy, not to mention that untreated depression and anxiety can have impacts on the development of the fetus and on the person's well-being.
Yeah. And I do want to talk about that a little bit as we get into treatment. I think that's a really, really important point. Just to back up a little bit, as you were talking about who is at risk of developing postpartum depression, in general, who should we be more concerned about? Who is at risk of developing depression or anxiety in pregnancy? And then again, in the postpartum period?
So the biggest risk factor is pre-existing history by a long shot, right? 3 to 4 to 5 times greater risk, especially if untreated in that preconception period or in pregnancy, right? So that's the biggest risk. The other really big risk factor that is really important is social support. And so when we think about social support, we're talking about practical supports, like instrumental supports, practical supports, as well as kind of emotional supports. And so lack of social support is a huge risk factor. And then the third big bucket is like major stressors. So, is it an unplanned pregnancy? Is there something going on in the relationship? Is there a major financial stress? Is there a complication of the pregnancy? What about the child illness, right? So these major stressors, sure, sometimes they can just cause stress and not necessarily a mental health disorder, but they're the big risk factors. So basically, personal history, especially untreated, social support, and stress. There's also some evidence about, maybe family history, like if sisters and mothers have had that, as well as if people have had mood issues around their periods in the past. So we always ask that too. Like maybe you are genetically kind of more hormonally sensitive. You're more sensitive to the fluctuations in hormones. That's pretty specific, but really it's those big 3.
Okay, great. Thank you. Dr. Maxwell, so if you have a patient is at risk for depression or anxiety in the pregnancy or specifically postpartum, what are some of the things that you talk about with your patients in terms of preparing, let's say, for the postpartum period? So how can we set the stage to, ensure, more success in the postpartum period and to prevent of mood or symptoms? So what are some of the tools or strategies that you talk about with patients in preparation?
This is a reset moment. I just paused for a second. There was some background noise, so sorry about that.
Okay.
Thank you for the question. I think preparation for patients, for pregnant folks, for the postpartum period is really important. I was thinking just back to the last question that Dr. Vigod was responding to, in terms of who's at risk. Also, what comes to mind are some of the populations that we serve. For example, from racialized and Indigenous backgrounds, as well as immigrant populations. I suppose, there could be unique stressors that folks in those communities face, which may be at a point to contribute to mental health issues during pregnancy and postpartum. So I just wanted to mention that. I think that as part of our job as pregnancy providers and people who are caring for pregnant women who may have mental health issues. Identification during pregnancy is really important. And as I mentioned, I do try to ask at most visits and certainly in the postpartum postpartum period, we have a structured way of doing that as obstetrical providers. Throughout the process, though, where we're screening and asking these questions, if we do identify a problem, it is really important to know what resources are available. And so within the program that I work in, we do have a perinatal mental health program, which involves different counselors and therapists and psychiatrists as well, who provide care to our patients during pregnancy and for a period of time during the postpartum. It may be that in some settings, accessing that type of care and those resources may not be as easy. So I think that the resource that Dr. Vigod has been so instrumental in developing, the CanMat guidelines that she mentioned a few moments ago, will be really helpful in educating more providers about the types of resources that can be accessed, and make people and providers more aware of what resources may be nearby. But I do worry about the access and the capacity of our health system to be able to provide all of the care that is needed, because mental health issues in pregnancy and peripartum are so common.
Okay.
In the CanMat guidelines, we did actually look at this question of prevention, like what can prevent, particularly in people at high risk. And there's probably more than we thought there was. So for example, we looked at what we call sort of lifestyle factors. So couple things really interesting. One is that exercise and regular exercise has some evidence for the prevention of depression and anxiety perinatally, and also some evidence for the treatment, even on its own, of mild symptomatology. And so, of course, a person needs to speak to their antenatal care provider about what exercise might be appropriate. But we're talking about evidence even from walking 3 times a week can actually has evidence for prevention. The other prevention thing is sleep. So when sleep gets really disrupted in pregnancy or in the postpartum, we want to think about ways to protect sleep. So in people who are really high risk of relapse, who don't do well with sleep deprivation, you can think about ways, perhaps they might pump a bottle and a bottle's given by the partner at night, or there's sort of a sleep schedule, or, maybe they can get some help so that they get more regular sleep, right? Or for people who are actually experiencing insomnia, that, they can be treated with cognitive behavior therapy for insomnia or with medications. And, sometimes you can actually avert a full mental health crisis with sleep. The other types of interventions that have evidence for prevention, peer support has huge evidence for prevention, especially in people who have some of these risk factors that were mentioned, including underserved and racialized populations, as well as people who maybe have a few symptoms but haven't developed a full disorder yet. And peer support is where peers who have experienced this in the past are trained to provide support. And there's a ton of peer support available in Canada through Life with a Baby is one of the main Canadian providers, and also Postpartum Support International. People can do online peer support. A lot of the public health programs also do some peer support, and it has really high level evidence for prevention and for treatment of mild issues. The other interesting thing, you can stop me if I'm
No, this is great. This is sort of what this is great.
The other thing is, we think about education, and we're always saying, educate your patients. So we also looked at, what education? Of course we should educate people and tell them about things, but are there any specific education programs that are actually preventive or can treat mild illnesses? And there's some evidence I thought this was fascinating, for what are called co-parenting programs. So actually having parents have education around how to navigate their roles together as parents and role expectations and things like that. And when you really think about it, it's not actually surprising, but again, because it probably helps with the social support and reduces the life stress, right? All the risk, it probably reduces the risk factors, but there's actually evidence again that it can prevent and possibly, treat mild disorders. So before you even get into, referring for psychological therapies, or referring for someone to start on medication, it appears that there's actually a cadre of quite available. Imagine in our prenatal programs, if we started incorporating, those prenatal classes, looks like if we started having some co-parenting modules, we might actually do a lot of good. So I'm hopeful we could think about things like that. I mean, the other prevention pieces in people who are already on medication, you need to really think about, prevention might actually be staying on their medication regimen, right?
Yeah, and we're going to get into that a lot, but I absolutely love that, Dr. Vigod, because I think we think about reproductive mental health and then we go medications, treatment, but there's so much we can be doing in a preventative way, which have evidence. And it's just important for us as healthcare providers to think about, are we doing enough to talk about those things in the perinatal period? So I absolutely love that. So thank you for that. And if it's okay with you, can we start talking about medications? Because we know that is a very common question. And as you said, it's with patients who are already on a medication for their depression and anxiety and are now thinking about, do I need to come off of this medication? And perhaps it's prior to trying to conceive. Perhaps they just found out they're pregnant. Or somebody who's really suffering potentially, or not very, really suffering or having symptomatology, as you explain. And they might benefit from a medication. So how do you navigate those discussions? And I know that's a very large topic, but how would you start this discussion?
It is such a large topic, and I will draw on something that Dr. Maxwell said about stigma, right? A lot of research suggests that if you say to a pregnant person, I'm really sorry, but let's say your diabetes in pregnancy just isn't being controlled by diet, I think you're going to have to take insulin, right? A lot fewer questions come than, I'm really sorry, but your depression's not responding to the non-medication treatments. We need to talk about medication. For some reason, people feel they feel a lot of things. They feel like they failed. They should be able to have control, and so there's something about the mental health piece of it that I think is really hard for people. What I start saying to people is, listen, we're going to have a discussion about medication, but the biggest thing to think about is we're not having the discussion about medication for no reason, right? We have to think about what are the potential risks of you remaining untreated, right? So if you remain untreated with severe depression and anxiety in pregnancy or undertreated, you might be in a position where your quality of life, your experience of the pregnancy, your relationships suffer. The longer you leave someone untreated, the harder it is actually to treat them. So we might be setting up people for chronic, mental health issues if they're not treated, right? And then there's also the potential for, probably through the stress pathways, there's evidence that babies who's are exposed in utero to untreated serious depression, anxiety, they may be born smaller, they may be born a bit earlier. We think that there may be, there's such a higher risk of postpartum depression in the mom, and then that gets linked, and then that can have impacts on the child's social, emotional, and physical development. So I always first say to people and then the other thing that can happen is if you're really, really depressed, maybe you're not eating well enough, or maybe you are smoking to control your stress, right? So then it might not even be direct, but there are other things that can be going on, right? So I would say we need to sort of weigh that, and we need to weigh the severity of your depression and the potential impact of you remaining depressed or anxious and what that could do, right? And for people, let's say, with more serious mental illnesses, let's say bipolar disorder, schizophrenia, the risks of coming off medication are really, really high. And they might even be in positions where something really negative could happen, or they wouldn't even be able to parent, right? So, we have to think about that. I always say that to people. I say, we're not talking about medication for no reason, right? And then you kind of go into, what medications might be options. And it's a hard conversation because I think, and I'm interested in what Dr. Maxwell thinks, but with obstetrics and with having a baby, you can never tell somebody anything is zero risk, because you can never know. There could be an outcome that happens. So what I often say to people is there could be an outcome that happens, but for the most part, the chances that it would be because you took this medication are pretty low. For most medications. There are a couple of medications that we really like don't use in pregnancy, not so much for depression, but for some of the other conditions. And we like to use medications that we have a lot more information about. So that's generally where I start with people. And I also try to validate that, I try to understand, is this a hard decision for you? And also, how much do you want to know? Some people want to know everything, and some people want to know less, right? And so just to really validate that this can be a really complex decision where there isn't necessarily a treatment option that you can choose, including the path of no treatment, that doesn't come without risk for something undesirable to happen. And that's a really hard place to be. It's a really hard place to sit. Now, we did a study that we've actually just completed where we made an online patient decision tool to help patients make decisions about antidepressant use in pregnancy. What the tool does is sort of explains to you, like, why might you take it? What are the potential benefits? What are the potential risks? How do you value those things? How are the support system around you helping you make the decision? And what's really interesting is, the results coming out of it are doing the tool versus like usual care. It really helps people's comfort with the decision. And because people just have really high levels of confusion and self-blame. And a lot of people talk about, I'd rather not take medication because at least then I didn't do something that could cause a problem, right? So I think this is just such a complicated area, and it's so important to find a way to help people kind of see the whole picture and not just see the possibility that taking medication could cause a problem. That actually you have to kind of think of the whole picture, and maybe on balance, taking medication, the chances are of a better overall outcome for everybody.
Thanks, Dr. Vigod.
Such an interesting discussion around patients' perceptions, I think, of medication safety in pregnancy. I think particularly when it comes to mental health. I think it's instinctive for, a pregnant person to feel that, they want to protect their baby, and they're worried that any substance, any medication that they might take will, potentially harm the baby. And I find that when I engage in that discussion with patients, it does boil down to, in many instances, worries about birth defects. And so, I do spend some time talking about, what are birth defects and how often do they happen. A lot of folks maybe don't realize that in about 3 to maybe 5% of all pregnancies, birth defects can occur. And so, the chances that a single or multiple medications would cause birth defect are generally quite low, particularly when it comes to medications used for mental health in pregnancy. And it depends a little bit on, the timing of exposure. So, for example, whether people are taking medicines in early pregnancy versus later pregnancy, the dosage, certain combinations of medications. I mean, it's a complicated issue. So we do spend some time talking about that. It comes up a lot in my practice. And I do think that the concern that our patients have, it's coming from a good place, and that is of protection. But then I go back to what Dr. Vigod was saying regarding what is the risk of not taking the medication. And it's all the things that she mentioned, up to including nutrition, self-care, ability to exercise, ability to take care of oneself in pregnancy and in postpartum, which can really be compromised if you're not feeling well and if you're at the stage where you actually need medications. So I think that, with a dialogue to really kind of understand what are the risks, but what are also the benefits of having the treatment is usually an effective and helpful way to approach the conversation. But I do know that there's always those lingering doubts, and it's never possible, I think, for as care providers to say that there's no risk. We can never generally say that conclusively. So then it becomes a navigation over weighing, the benefits and the risks for each individual.
Thank you.
We know that patients with mental health issues would prefer a non-medication treatment, right? We know this. I think there's also some evidence that one of the things we were talking about before about why don't people come for help is if they're afraid to come and talk to someone like me because they're afraid I'm going to say it's medication, it's only medication, and that I won't be open to that. So I do think it's important to say there have been lots of patients where maybe I thought that, medication would get them better faster, but I'm still going to see them and treat them and have them work on psychological therapy and have us continue that dialogue, right? Because the most important thing is that the patient gets treatment and gets what they need, right? And so I do think it's important to sort of, for providers to really state that openly, so that people don't not come for care because they feel like there's maybe only one thing that's going to get offered.
And Dr. Vigod, just to add to that, in terms of other treatments in addition to pharmacotherapy that have evidence for depression and anxiety in pregnancy, what would be some of those options? So you said therapy.
Yeah, so I mean, we often talk about a stepped care model, right? In mild, we're looking at those lifestyle and more sort of psychosocial support things that we already talked about, like the exercise, sleep, peer support, co-parenting, support groups, things like that, right? But once someone has more significant symptoms, really the first line treatment would be a psychological therapy. And so the ones that have been best studied are therapies that some people have probably heard of, like cognitive behavior therapy, or CBT has been really well studied. But so have some other therapies. One is called interpersonal psychotherapy, which really focuses on the role transition and kind of grieving previous roles and dealing with interpersonal communications with partners. Like it really is, it's really amenable to the perinatal period. There's another treatment that is similar to cognitive behavior therapy, but it's called behavioral activation, where people really look at what are their values and how to kind of do things that make them feel better within their values. And it's like very practical and has lots of really good evidence as well. There's some evidence for depression, less so for anxiety, for mindfulness-based therapies, which is not to say that other types of psychological treatment wouldn't necessarily work. It's just they haven't been studied as much. But some things that are really important are, it doesn't necessarily have to be like a one-to-one in-person appointment. So there's some really good evidence now that doing it virtual, like video, either one-to-one works, groups work just as well as in person, sometimes better than individual, because I think there's that shared experience. And also there's some evidence for what we call like facilitated self-help psychotherapies. So people might get modules, for example, online, but then they also have a coach who helps them, and those can be very cognitive behavior therapy based. There's even, then there's evidence that these don't even necessarily have to be delivered by a psychiatrist or a psychologist or a trained therapist. That a colleague of mine is just completing a study where perinatal nurses and midwives, were trained to do one of these structured therapies under supervision, and it was just as good as when the psychiatrist did it. So I think we have a lot of options for how to deliver these psychological therapies. So, I think there are a lot of options. One issue we have, of course, in Canada is access, because a lot of therapists, like for example, psychologists, social workers, if they don't work in a hospital or in a family health team, then they're not covered by the provincial health plans. And so only if people have their own insurance for them. And then to speak to what Dr. Maxwell said, we don't, like in terms of sort of underserved populations, might have more stress, and that might contribute to increased risk for these, but also have issues with access to the evidence-based treatments. And so it's like this combined might have increased risk and might have under access to the treatment.
Yeah, I'm thinking, as a family doctor, I mean, this is our biggest concern is, so we identify our patients, and now how do they receive that help? How do they access it, especially for people that don't have coverage for therapy? You mentioned so many different options that I'm not aware of even, and we work at hospitals very close to one another. And so I'm imagining how many other healthcare providers don't know about all these resources. So is there somewhere, and I know this is a very simple question, somewhere online that has a good list of all of these resources so that we know, we feel supported when we have patients, know where to offer or to send patients to?
Yeah, so there are, there are a number of lists. A few of the provinces have now developed care pathways. Ontario has one, Nova Scotia adapted one, I think BC has one that have some specific lists. The other place is Life with a Baby that I mentioned before. They keep a pretty comprehensive resource list that was being kept by the Canadian Perinatal Mental Health Collaborative, but it's now been transferred over to Life with a Baby. So that would be something that I would suggest people look at. Postpartum Support International also, as well as the Pacific Postpartum Society, has a lot of British Columbia specific resources. one thing that we're doing in Ontario right now is the 5 big perinatal psychiatry programs in Ontario run out of my hospital and 4 of the other hospitals. We've come together, and Dr. Maxwell's part of this project. We've been funded for a project where we're going to open like a patient-facing, anyone can come to sort of a website to sign up for being able to see like a knowledge center full of resources and treatment options, and also have access to a care coordinator who will help them figure out what might be right for them. Like what I was talking about, like, do you need the stuff that's maybe for more mild or moderate, or, would your family doctor like to speak to one of our specialized reproductive psychiatrists for, to talk about what medications might work, or do you need to maybe go to one of our more highly specialized programs because things are more complicated for you? And one thing that was really interesting was we did a pilot study of this, and we had about 100 people, and 48 of them were in the group that we tried out this, platform with. And a few really interesting things happened. One was, can you guess how many people actually of the 48 people needed to speak to the psychiatrist in the end?
1.
3, right? Everybody else was, the psychiatrist weighed in. There were a couple of times that the psychiatrist spoke to the family doctor, but in general, people were found and given services. And at the end of being in the program for 6 months, 75% of the people who were in the intervention group had a score on their depression scale that was considered in remission, versus only 50% of the people who had been in our usual care group, to whom we had given some PDFs and some information, right? Like we do of usual care, but that's a pretty big difference. Like that's a bigger difference than what we see when we treat people with antidepressants, right? So, I think we're moving toward that kind of coordinated care, because it really helps get, it helps save the few psychiatrists that exist for people who maybe have more like complicated problems, right? But it ensures access to all these treatments and quickly for people who can benefit from them. So we're really trying to kind of shake things up and find a way to do what you said, which is, when you identify those people in your clinic, or a person identifies themselves or their spouse or their partner, right? It's
where
really
to go from
obvious
here.
Where to go from there.
That's amazing.
We have evidence-based treatments, right? Yes, we can always learn new things, and we can always design different treatments, and I hope we do, right? There's lots of really interesting research going on. It'd be great if there was a way we could just, have
Right.
something that prevented all these things, but there is a gap between what we know works and what we're actually doing. So we also have a responsibility to figure out how to fill that gap.
I love that. Thank you for that. Dr. Vigod, one last question, and this is just about medications again, because this is obviously a question we get a lot. What about medications while nursing, while breastfeeding or lactating? The safety of medications during that time period.
Okay. So the first thing that I always say to people is, once the baby's out, like, you do have other options, right? So if you were really worried about the medication and lactation, like, you do have the option of not breastfeeding or chest feeding, right? Or not supplying breast milk. And I do think it's something important to talk about, especially with mental health, because we know that when people have a lot of difficulties with breastfeeding or chest feeding, that can also increase their risk of developing a mental health condition, right? And so on some level, sometimes I do think it's important for us as providers to be able to help people like take a minute and actually remind them that they do have other options where their baby can still be fed, right? It might not be worth the negative impacts of being so ill from continuing to try, like, help people to weigh it, right? Because there's so much pressure for the breastfeeding or chest feeding to work out. So I do think it's important for us to remind people that there might be other options, right? And sometimes, especially like if you have severe mental illness, if you're taking a medication that, could potentially have impacts, like that's a real possibility, especially when we need to protect your sleep, right? So I do think, and this might come across as controversial, but I really do think it's important to have the conversation that there are options for it's okay to prioritize your own mental health, and that your baby isn't going to be harmed by you protecting your own mental health, right? So That being said, the majority of psychiatric medications are very low risk in lactation. The majority pass, less than 10% into breast milk, which is generally considered compatible with breastfeeding. It's not the only thing that we look at. Something could pass less than 10% and still cause problems. But in general, most psychiatric medications pass less than 10%. Some of them barely at all. Like there's some that you can't even detect in the breast milk. And in general are not associated with major issues. I do think it's important to have the conversation because there are medications that we would sort of prefer because maybe they're, a little bit shorter acting, or maybe they've never been associated with adverse effects when some others maybe are, a little bit longer acting. So they'd be in the baby longer or could potentially theoretically cause problems, right? So they're sort of, if you look again, I keep talking about our CAN-MET guidelines, but they're so fresh, but that's how we sort of classify like what would be the set of ones that you might choose first and then go to the next ones if those first ones don't work. And that can be really helpful because unlike pregnancy, where a lot of people in pregnancy have pre-existing mental health issues, in the postpartum, you've got a lot more people who I think are considering medication for the first time. But one thing that I will say is that there's almost no medication where I would say someone should switch to a safer one for lactation because the differences between the medications are generally like pretty small. And if you switch from one medication to another, you risk relapse because it doesn't mean that the medication's for sure going to work. So again, with some, I'm being vague because, but like with some exceptions, in general, it would be very rare for us to suggest that someone should switch a medication that's been working.
Okay, great. Thank you for that. So we're coming to the end of our chat, and I'm just wondering if either of you have any last minute words that you want to leave for the audience. I'll start with Dr. Maxwell, if there's anything you want to end off with.
Thank you, Dr. Bogler. I think I'll just pick up a little bit on what Dr. Vigod was discussing around the lactation part. And, I think it goes back to that discussion about the risks and the benefits. I did want to mention that there are still tremendous benefits to breastfeeding, to chest feeding. And we know that it creates an important opportunity for mother-baby bonding and, the transmission of useful and good immunity from mother to baby. So I think in the majority of cases, the benefits of continuing to breastfeed and taking a medication for a mental health condition would be the right thing to do. And so I hope that if folks are listening out there, know that there are resources. I think we heard about prevention, which I think is so great. Some of the things we talked about, Dr. Vigod, you mentioned exercise, I think, and nutrition as well. For prevention of mental health problems. Also important in so many other areas of health and pregnancy. And it is recommended that, people exercise 150 minutes per week throughout pregnancy, all trimesters, unless there are clear reasons that a person shouldn't do so. This can help with prevention of, future illnesses and hypertension and diabetes. So I think so many good pearls and good pieces of information for people to take away from this discussion.
Thank you. Dr. Vigod.
Honestly, I would just say, mental health issues are real around the time of pregnancy, and people need to know that there are treatments out there and that they deserve to get help. So, I would say if, when we did make I was showing everybody before, we did make a patient and family guide that goes along with our guidelines that you can find on the canmat.org website. I think it's maybe not something that someone would necessarily have time to read through when they're in the midst of a crisis, but maybe something that people would want to pick up, in preconception or in pregnancy and use that to sort of start learning about what some of the prevention and treatment options are.
It's great. Or something that we can even have in our offices as well for patients
to look at
while they're waiting. Oh, please do. I would love to have one in my office. Thank you. I'm going to expect something in the mail. I'm going to hold you to it. So this brings us to the end of today's episode on the importance of mental health treatment during pregnancy and lactation. We've explored why mental health care is just as vital as physical health care, the risks of untreated conditions, and the safe and effective options available to support parents during this critical time. I want to say a huge thank you to our experts, Dr. Maxwell and Dr. Vigod, for their knowledge and insight today. I just want to add one more thing, because we were talking about mental health and, suicide thoughts. And if you are thinking of suicide or hurting yourself in any way, please ask for help. Please reach out to the Suicide Crisis Helpline at 988. You can do that by phone or text, or visit 988.ca in Canada or the US. You can also call 911 for urgent help or go to your nearest emergency department. For more resources on this topic, including First Exposure's full information sheet on maternal mental health, visit firstexposure.ca. And thank you to our listeners for joining us. If you found this conversation valuable, I surely did. Be sure to subscribe, share, and stay connected for future episodes. Thank you.
The First Exposure team acknowledges that our office is based on the traditional territories of the Anishinaabe, Wendat, Haudenosaunee, and the Mississaugas of the Credit, though the impact of our work can be felt across Turtle Island. First Exposure is committed to nourishing respectful relations with Indigenous communities, whose knowledge of medicinal plants and environmental substances are a foundation of the pharmaceutical science on which First Exposure depends. This project has been made possible thanks to the vision and support of the Vora Miller Foundation and the participation of the Dalla Lana School of Public Health at the University of Toronto and Health Nexus.